Hi, I'm Dr. Salil Khandwala and I'm the Medical Director at Advanced Urogynecology of Michigan. On our website, www.augf.org, you will see a lot of educational information under the tab Educational Seminars. I've made a lot of videos to help our patients improve their care and come up with understanding of their different conditions. Today, we're going to talk about what is this DISST procedure that I have invented called the Dynamic Interactive Standing Sling Technique. Let's do a little basic understanding of what the female anatomy is, and I'm sure you probably have seen this in one of my previous talks, but this is the head end, this is the foot end, this is the front, and this is the back. You got the bladder right here, the urethra is the tube that brings the urine outside, vagina is behind that, uterus on the top, and the rectum at the back. So this is the typical orientation of the pelvic organs. The bladder is a storage organ and it empties when you want it to. Until then, it's just storing the urine that's coming from the kidneys and the urethra stays tightly closed. All this is under the control of the nerves and the nervous system. Something that we talk about is a condition called hypermobility. So if you look at the bladder and the urethra, when the patient coughs, it should stay there if the tissue supports are good. But if the tissue supports are weakened, it may seesaw or fall back more, and this angle changes, and that anything more than 30 degrees is considered hypermobile. So let's take an example why stress incontinence happens. So stress incontinence is essentially leakage with strenuous activities such as laughing, coughing, lifting, sneezing, like how she's coughing and she's leaking. So the dotted line here is where the bladder is at rest, and this dotted line is where the urethra is at rest. This junction of the bladder and the urethra is called the bladder neck. When the patient strains, the tissue supports should keep it there and prevent it from falling back. However, if the tissues have weakened, then it'll fall back and open up or funnel open the bladder neck, drop its pressure down, and this results in urinary leakage. This is one of the most common types of stress incontinence. A treatment that has been recommended is called a single incision sling technique. Single incision, that means there is just one incision which is inside the vagina. And this has been the typical sling which I use now. It's called the Solex sling. It has got two hooks or barbs at each end which hook into the muscle. And this is about 8 centimeter long sling and 15 millimeters wide. And that stays under the urethra. So the incision is under the urethra. So you're looking at the legs are up. This is the vaginal opening right here. This is where the urine comes out from, called the external urethral meatus. This is where the incision is, just right under that in the front wall of the vagina. Where we take the incision, then the sling is placed and the anchors are placed in the muscle on either side. And now you have the sling providing a backstop for the urethra. So when the urethra is trying to fall back, it cannot, because now it has a nice little hammock support under the urethra to restore continence. Why do I do this particular technique? And I'll talk about the technique too. So the published results with the single incision sling, the technique I just showed you, was 55 to 65% success. Now that is quite low when you compare to the long slings. The long slings used to come out into the groin and the lower belly, and these had about 85% success. So most studies show that this single incision sling is inferior to those long slings, and the complication rate is no different. The initial perception was that if you make just a small incision, you should have lesser complications. And what these studies found is that it's similar to those long slings. These long slings do not have any more complications than the single incision slings, but most importantly, the success of these single incision sling is not good compared to that 85% success of the long slings. So that many societies across the world have questioned the value of the single incision sling and saying, is it something that we should ever do for management of urinary leakage? The premise of our technique, the DISST technique, is that the sling procedure, or for the matter any bladder suspension, is done with the patient under anesthesia and therefore laying on the OR table flat. A sling that may look good to me as a surgeon may not be good enough for the patient, but the only way you would know is when she eventually stands up and coughs with a full bladder, and then she'll know did she leak or not. But that is a little too late because that doesn't happen during surgery. It happens after the surgery is completed, after she's gone to the recovery room, and then when she goes home and she stands up and coughs, and she notices it's not tight enough, I'm still leaking urine. More importantly, when do patients complain of leakage? Well, it's in the upright position. Very few complain of lying down. It's usually when they're doing jumping jacks or running or standing and coughing. That's when leakage happens. When we did a simple office analysis, we found that 1/3 of women leaked standing and not lying down for the same amount. So we had her cough lying down, then we had her immediately stand up and cough, and she leaked. And we saw that in 33% of the patients leak standing up and not lying down. So lying down and checking things is not really the right way of doing it. So the poor results that I told you have been typically been blamed on the sling not being tight or becoming loose. My question is a sling becoming loose, or did we not place the sling tight enough in the first place? That led me think that let's do this particular technique. So what does that mean? First, I started doing the sling under local anesthesia because the goal was to see if I can have her stand up. Now, I can't have her stand up if she's numbed or anesthetized, so I mastered it under local anesthesia. Once we could do it under local anesthesia, then I came up with a contraption to have the patient stand up safely in the operating room. And finally, we tested it over 250 patients now. So this is the contraption. So if she's lying down here, this is a platform I created for her to stand up, and this can be moved up or down. And this is a bar that she holds on when she stands up. So first what we do is, as we're doing the procedure, patient is lying down. So this is the bladder, this is the urethra. In a lying down picture, this is how it looks. We have her cough, and sure enough, she leaks. Then we do the sling, we place it under the urethra. Then I look inside the bladder, make sure it's okay. Then we fill the bladder up. And as we fill the bladder up, we make sure that the amount that has been filled is exactly like what it was when she complained of leakage with fullness. So we fill her to her fullness amount, and of course she's awake, so we know how much to put in, because she will say, yeah, I feel full. Once we confirm that the amount is correct, then I have her stand up. So now she's standing holding that handlebar, and on that stool, she's standing, she's coughing, she has a full bladder, and we confirm that there is no leak. So this is what we call the DISST success. Standing, full bladder, coughing, no leak. When we followed these patients afterwards, we followed 78 patients at least a year out, and our success was 97.4% were dry. Urgency leakage, even the go leakage improved. Their sexual function improved. Now you wonder, why would sexual function improve? Because several of these patients, several of them, they complain of leakage during sex. So they don't want to have sex, so they feel inhibited during intercourse, and there is no enjoyment. Now you're not leaking during intercourse. Obviously, it feels good to have sex because there is no fear of leakage. We did not have any injuries or no sling or mesh erosions. Nobody had difficulty emptying or retention. No history of recurrent or frequent bladder infections. We did not even use a catheter during the procedure. We then followed a larger number of patients 2 years out, which is almost 140 patients. Same results, 94 patients satisfied with their results. No patient had any complications during the procedure. All of them were sent home the same day, and no patient had difficulty emptying the bladder. So bottom line, what our results showed is 95% of our patients were cured even up to 2 years out. No complications. And we had two different types of that single sling that we tried, and it did not matter. The results remained the same. So this showed us that, confirming that when the woman stands up right in the procedure room, because if she stands up and she coughs and she leaks, I can always tighten the sling because I'm right there. However, once the procedure is done, I can't do anything about it. It's over. So let's see what are the different considerations that we have now that we are about to do this in the office. First, we get a medical clearance to make sure that everything else medically is fine, especially if someone has high blood pressure. We then give them a Valium tablet at night and the morning off just to calm the patient down. Someone should accompany the patient to the procedure room. Make sure you take all your regular medications and you can drink liquids. That's not a problem. Any metal like rings, earrings, or any other rings should be removed. No nail polish, no body lotion. And we may teach you how to catheterize, even though it's extremely rare to do this. When you come in, we check your vitals, you get an IV started. Do not need IV fluids, but just get the IV started in case we need fluids. We give you something for pain called Toradol, and I'll talk about this anesthetic gel application and do a pregnancy test if it is necessary. And patient is asked to empty her bladder, and we make sure that the bladder is empty. So what about that gel? So this is, again, remember the vaginal opening right here. This is the urethra where the urine comes out. This is the front wall of the vagina. This is where I'll be making the incision. So I apply the gel here using this 5% lidocaine gel, which is applied right in the front. So this is what you'll be looking at, so looking at people who look sort of different, right? But now everybody has seen ER or OR. So you can see that this is how we look with a mask. This is my team that's completely sterile. So this is a completely sterile procedure. And then there is someone who's sitting next to you who's not scrubbed. This is the scrub team. There's someone sitting next to you talking to you and monitoring your vitals. And there's someone who's walking around the room helping us because we cannot touch anything which is not sterile. So the blood pressure is being continuously monitored, and so also your heart rate. And then we have this typical contraption I talked about, which is the harness bar that you hold to stand up and the platform that you stand up on. First of all, your legs are placed in this particular position called the dorsolaryngectomy position. And this is important because that allows me to get in between the legs. Not just me, but even my assistants can come in to help me so the procedure is done correctly. So here, your legs are up, you're completely covered up. This is where your head would be up here. And now I'm working at the bottom, making sure that I have enough access and enough light from the OR light and my headlight. So again, I make a small incision in the front of the vagina. We put the sling in, make sure it's properly attached. Then with a full bladder confirmed by the scan, we have you cough and cough, no leak. Once there's no leak, the procedure is completed. Once you go to the recovery area, you'll be asked to empty your bladder. You'll have some vaginal bleeding because I leave a little gap. It's almost like a light period that stays maybe that day and for a few days thereafter, but it gets lighter and lighter. The first time when you stand up, you may see a few blood clots because that may have happened during the procedure. So don't be alarmed if you see blood clots in the toilet bowl when you get up to go to pee the first time. You're discharged home when I make sure that you're emptying completely and your vital signs are stable. On discharge, we don't even give our patients any pain medication. So if you have some discomfort, you can take like Motrin or ibuprofen. Most of my patients tell me they do not need anything at all. So as I mentioned about the slight bleeding, you'll find that the urine stream is slower, but that's normal and that gets better over time. And what we tell our patients is avoid lifting anything heavy and no intercourse. The no intercourse part is because you have a stitch inside the vagina and you don't want it to be disrupted and opened up. Now, activity-wise, you can do almost everything. Really, there's no restriction. You can go back to work the next day, but just avoid heavy lifting. I mean, significantly heavy that you're lifting, you should avoid. But if you're doing regular walking up and down, no issues. What is the advantage of this? There's no anesthesia required, no need for IV fluids. Because of no anesthesia, there's no risk of nausea and vomiting after the procedure. We do not put a catheter in. Therefore, there's less risk of bladder infection and bladder irritation. It's a quicker post-operative recovery as you're completely awake. And since we do not use anesthesia, it's less cost to the patient. So bottom line, it's a game changer. Remember, patients leak urine standing up, not lying down. This is what's happening. I put this in. Think about this. Now, same thing you're doing. You're standing up. Her bladder is empty. Now, I have filled your bladder up to fullness, and I'm watching with my headlight, and there is no leak at all. Nothing is left to chance. Now, this is important. It's not up to the surgeon's decision or judgment. Oh, I think it looks tight enough. It's not left to chance. We know right away. It's what you see is what you get. You stand up, you cough, no leak, it's all done. Why undergo a procedure without knowing what the outcome will be? Are you ever, is a bride ever going to buy this dress from Amazon.com or any.com and have it delivered to her wedding place and wear it for the first time at her wedding? Well, no. So why can we not therefore trial this out with a sling? Before the sling, this is something that I often used to talk to my patients about, laugh so hard tears ran down my legs. Well, now you'll be able to laugh and laugh and laugh, and tears will run down your eyes and not your legs. So let me tell you this. Granted, going in that position with the legs up in the lithotomy position, it's no fun. It feels slightly, yeah, embarrassing, maybe ridiculous a little bit, putting legs like that. But, once you understand why I do it under local, without local, I cannot have you stand. What do you want to achieve with this procedure? You want to be dry. You're coming in for the procedure so that you do not leak. What's the best way I can do this? Is if I have you stand up with a full bladder and cough really hard and you don't leak, it's over. If you're still leaking, I can tighten that sling right away. Nothing is left to chance. So remember, if you want to get the success that I have enjoyed, we have to do this under local, and you must be able to stand up. Under anesthesia, it's a toss-up. We don't know. And that's why the results have been very poor with the single incision sling, but not when done by our technique. At the same time, it's done with minimal. You'll feel my finger touching the muscles. The discomfort is slight, almost like when you go into a dentist and they numb it. Very similar to that. But remember, when I'm putting the numbing liquid, it's numbing it. So the pain gets even lesser and lesser and lesser. And ultimately, when you stand up and you do not leak, you right away know it's over. Thank you.